have now created a 22-member council made up of individuals from all over the world who are the so-called individuals who are experts in the field to work with, to help figure out how to bring all the knowledge base For the last 25 years, Fibrodysplasia Ossificans Progressiva community has moved from the wastelands of a rare disease to the watershed of clinical trials. Together we identified the genetic cause and used that knowledge to spearhead worldwide research efforts to develop therapies that will transform the care of individuals with FOP. We've expanded the frontiers of discovery and drug development, dismantled the physical and perceptual barriers that have impeded progress, and inspired global research in small molecules, antibodies, and gene therapy. And we have formulated best practices and assembled teams of experts to optimize ambulatory and inpatient care of the FOP patient. Why do we need individuals from across the globe? Is because I think in dentistry, we still have perceptual barriers. We still have barriers of care where individuals are not familiar with current best practices related to treatment, particularly to this particular disease. And if we can get a core group of individuals that are not only interested but familiar with the disease to treat these individuals, I think that becomes a huge benefit to these individuals and society. So what is meant by the sleeping bear is that the FOP gene essentially resides in an individual. So as I mentioned earlier, they're born with the malformation in the toe, so they have the gene. What is not known to this day is specifically what triggers that gene to start to function. So why does the gene remain quiescent and then suddenly it awakes? And when it awakes is when you get the heterotropic ossification processes occurring. And that's what's referred to is the sleeping bear is the sleeping gene that becomes awakened. And when we awake that gene, the grizzly is essentially the analogy to the awakening of the heterotropic ossification in different centers of the body. Slowly starts moving in the other direction, so that it'll often start in areas of the back, and by the time that individuals are in their late 30s, 40s, that's when it starts to hit the TMJ. Now, if you give, for example, a mandibular block in a child who is 3 years of age, you can activate the gene to get heterotropic ossification in your TMJ, and that child will no longer be able to open their jaw. So you'll get ankylosis of your TMJ and you're done. So you want to try and minimize the impact or the waking of that sleeping bear. And so everything that I talk to is anything that we look at that may trigger it. So an injection into muscle triggers it. Infection, trauma triggers it. The anoxia triggers it. So if you are, for example, keeping your jaw open for a long period of time and you get anoxia in the muscles, that may be a trigger. Now, it doesn't always trigger it, so we don't know when it is and when it isn't going to. And that's why one of the things that is done, if you have a look at the recommendations, is prior to dental treatment, especially if you're going to be doing anything other than just, say, a cleaning, if you're doing any kind of invasive treatment, you have to give the individual a pre-course of cortisone to try and minimize waking up that sleeping bear. The important piece here that you want to give to your viewers is that anything that we do, we want to minimize the risk of awakening or triggering the onset of the disease process. So whatever it is that you do, and with that then, the corollary of that is that we want to highlight the importance of managing the risk of getting the disease in the first place. So we do not want to get cavities. We do not want to get periodontal disease. We want to do everything we can to minimize that. Why do people even choose to work with individuals with special needs? So you're addressing this to individuals theoretically who already are working with folk with special needs. So the key is what can be compelling for them to work with this population group. If they're already working with people with special needs, all they really need is a little bit more information that will make them feel more comfortable, because it's about being outside of our comfort zones. When we are outside of our comfort zones, we don't like to do something. But what is it that allows us to get into the comfort zone? So what is it that pushes you to move outside of your comfort zone? And essentially, one, it's in some ways, it's courage. The majority of individuals with FOP and their families are probably far more aware of the medical and scientific basis of what's going on than any professional that they actually meet. And all we really need to do is regard them as the expert and ask them the questions, and they will give you the answers. Say you have to do extensive restorations on all the mandibular teeth, or you have to do extractions of wisdom teeth. You really cannot use local anesthesia because you can't give a mandibular block. So therefore you are required to do that using general anesthesia. So the general anesthetic, if it's done correctly, you can then end up doing the work that you need to do without waking the sleeping bear. So the requirement then becomes that you do a general anesthetic that is, and if you liked, I can send you the video of Dr. Grundwald, who's the anesthesia specialist, where he talks about this particularly. But what you need is an individual who has the ability to do nasal intubation with a scope that is not traumatic, and then you can then do the treatment that you require on that individual without impeding the long-term results of the possibility of triggering the gene that's going to result in ankylosis. So that's why I say I don't, I have one patient that had 1 millimeter of opening, and she was having episodes of regurgitation, so she was vomiting. And because she couldn't open, the vomitus was unable to expel any of the vomit, so she would end up swallowing it or inhaling it, which could result in some severe issues, right?
Right.
And so what we needed to do with her is we needed to edentulate her from the premolars distal so that she had a gap that if she did throw up, there was space for the vomit to extrude to her mouth so she wouldn't inhale or re-swallow it. So we did her under general anesthesia. In order to do her under general anesthesia, the anesthetist that I worked with consulted with Dr. Grunwald in Philadelphia. They discussed the process by which this would be done. And I also ended up having my oral surgeon discuss with the oral surgeon in Philadelphia what the processes were that they have used to minimize long-term implications. And then I worked with the two individuals, the anesthesia and the oral surgeon, with me in our hospital, which is a tertiary care hospital. And you're right, you would need a tertiary care hospital where you've got an anesthesiologist who is really well trained to do that type of anesthesia. And we were able to edentulate her from the premolars